So I now have the pleasure of introducing up our dynamic keynote speaker, Dr. Carolyn Brown. She will be speaking on the importance of oral health during pregnancy, and that also includes a question and answer session as well. Dr. Brown currently serves as a dental director, programs and development for the San Francisco Native American Health Center in San Francisco. Dr. Brown, in this capacity, oversees the dental clinic and manages numerous grants and programs. She has published several dental journal articles and serves as an advisor on multiple statewide committees. She is also an adjunct professor in dentistry at the University of California, San Francisco, the University of the Pacific, and a clinical site director for Lutheran Medical Center's Advanced Education in General Dentistry program. Dr. Brown attended the University of Maryland and Columbia University as an undergraduate, and the University of Maryland School of Dentistry for her professional degree. She is nearing completion of a master's degree in education from the University of the Pacific. So please join me in providing a warm welcome to Dr. Brown.
Good morning, everyone. So I started working with this idea of advocating for perinatal oral health when I was starting a fellowship that was funded by the California Healthcare Foundation in 2006. And I was told to, pick a capstone project and something that I thought I could have completed with, measurable results within 2 years. And that was 2006. So here we are 10 years later. And I'm still, carrying the banner and fighting the fight, thank you, for, advocating for perinatal oral health. And I'm hoping that I'm nearing the end of the first 10 years and turning the corner to work with all of you on the next 10, which I'm hoping really looks more at the advocacy, the education piece, the interprofessional work, the data collection, the quality improvement pieces that we're all hopefully ready to do. My goal is that you'll leave this room today ready to sort of embrace that. And, there have always been all of these questions and myths and confusion about this topic. I think that, we heard a little bit of it from Monica from the patient's perspective. Certainly, I've heard this from the dentist's perspective and also from OBs and midwives who, want to either refer patients but can't find dentists who will treat them, or from, patients who come to the dentist who say that their OB or their midwife, is really confused and doesn't think they should be, seeking dental care. So we'll get into that a tiny bit, and I think maybe, hearing some of what Monica said and maybe talking to one or two of you beforehand, there's still some concerns about the x-ray piece. So maybe I'll take just a couple minutes that I wasn't prepared to give during this talk to just talking about the x-ray piece, because maybe it would be a good place for us all to kind of embrace and get comfortable with. So you'll have to pardon me when I get to that, because I'll sort of go off talk here. So, some changes are coming. The feds have now addressed this issue of perinatal oral health, and there was a massive, consensus conference that was held at Georgetown University a year or two ago that really looked at this. And we're going to see this in the next CHIPRA. They're basically talking about, the necessity for oral health education to reduce and target and eliminate children's childhood caries. So some of this, they're still looking at the language, and the language that's in the 2009 version doesn't really have any mandate attached to it, but what they're writing for the next version will, we hope. Been working with some people through CMS that looks like that should happen. And, of course, we have some learning objectives, but I think that, I'll let you review that. Some of the things I just wanted to we have a really diverse audience here, which I think is wonderful. It means that we're getting closer to the science of spread, because you all go back and work with people who work in different areas. You're not just dentists and hygienists and dental assistants. So please remember to try and take some time to share what you experience and what you learn here with others through staff meetings or through your actual work. So I just want to talk for a brief second about, cavities and caries and periodontal disease. So these are some of the terms you might hear me speak of today. And gingivitis is basically an inflammation of the gums. It can be something that comes and goes. And in pregnant women, we often see this because of the amount of hormones that's in the pregnant woman's body, and also because of the amount of blood volume. Your blood volume doubles at about the 10th to 12th week, I believe. So, the tissues around the gums can be easily inflamed and can bleed. On the far corner here is the picture of a healthy gum, okay? And periodontitis is the ugly brother to gingivitis. It is a much more serious inflammation. It's one that tends to be more chronic, although it can have periods of being more acute. Once you have periodontitis, you don't get rid of it. It's sort of like diabetes. You have to manage it. And it's closely linked to diabetes in many, many ways. One of the things that we see in periodontitis is that with a chronic inflammation, you have all kinds of host reactions. The body does a lot of things and makes a lot of different products to kind of fight that periodontal infection. And when you're a pregnant woman, your body should be really producing all kinds of wonderful things to care for the baby, not fight a long-term infection. And dental caries. The thing about dental caries or cavities is really that it is destruction of the hard tissue. So it's a different thing. The gums are soft tissue, the teeth are hard tissue, in sort of dental speak. And it's caused by bacteria, and there are lots of contributing factors and risk factors that are involved. But I think the two things that are really important to understand is that it's transmissible. We know from DNA data that children get their cavities from their mother. As early as 3 months of age, that bacteria can be found in the mouth before the first tooth even erupts. And we also know that it's almost 100% preventable. One of the reasons that the Secretary of the Department of Health and Human Services is now being tasked with really mandating that oral health education be given to pregnant women regarding early childhood caries, because it's transmissible and because it's almost always preventable, okay? So here we are in California. We have a lot of babies in California. Okay, LA Basin, more than 1 out of every 5 births in the state is in this area. You have more teen pregnancies in this area, except for one other county. And, it's a very racial and ethnically diverse state. So we're really the first minority-majority state. And with that ethnicity also comes some more risk factors, both for dental decay and periodontal disease, and also for, adverse birth outcomes. So in LA County in general, the entire state has about a 6.8%, live births that are low birth weight. And in 2011, LA County was a little bit higher. You also have slightly lower breastfeeding rates. And, but you have pretty good rates of, first trimester prenatal care. So, for the OBs and those involved with the maternal health aspect, I think there's a lot of opportunity, although you're tasked with many other things during your appointments and your patient interactions. But I think that 81% in the first trimester gives me a lot of hope that there's great interprofessional work to be done. There are lots of known pregnancy risk factors. Some of them you might know and some of them you might not. Smoking, alcohol consumption, SES is socioeconomic status. But one of the things that, a lot of people don't know is 1 in 4, there's a whole lot of them we don't know. And this was really where some of the early work started in the 1990s, looking at could periodontal disease, this chronic, inflammatory process, be a player in this 25% of unknown causes for adverse birth outcomes. And when I say adverse birth outcomes, I mean either fetal death, low birth weight deliveries, or early deliveries. So, some of the things that we see when women who are pregnant have periodontal infection, there are associated adverse pregnancy outcomes. So they're also a little more likely to have preeclampsia and gestational diabetes. Also, a higher percentage of women suffer fetal loss who have periodontal disease. And Kim Bojas, who is an obstetrician out of UNC, who's done a lot of the work on the OB side around perinatal oral health, has summarized from all of her work that there's a 2 to a 7-fold increase in risk for pregnancy if a woman has periodontal disease at the time that she begins her pregnancy. We also have to go back to the pretty sister, remember? Ugly brother is periodontitis, pretty sister is gingivitis. Okay, we have to go back to gingivitis. We didn't think that gingivitis was as much of a player, but we have a publication in 2010 of the first fetal loss that was associated with gingivitis. So the bacteria that crossed the placental border that caused a massive lung infection in a fetus who could not survive and overcome that infection came from bacteria that is only associated with gingivitis. And they did multiple inoculations and tissue extractions from the mom because she was really overcome with grief and she was of higher economic status and education. And she basically kept pushing for them to find answers. And the only place that they found this particular bacteria was in her subgingival sulcus, or underneath her gum line from her gingivitis. So again, this is the timeline when it sort of touched on this. In the early 1990s were when the rat experiment started, mostly in North Carolina. And then we had several consensus conferences. And these were really aimed at a kind of initially breaking the nut so that everyone on board involved with healthcare for pregnant women sort of understood what was safe and what wasn't. And first New York State did it, and they didn't have as much money and as much resources, but they did a really good job of putting that together. And then in 2010, the CDA came along, and they partnered with ACOG this time, which I think was a really important step. And I was very involved in that process. In fact, it's what my California Healthcare Leadership Program, my capstone became, getting that funded. And I mean, they spent over $2 million in flying in experts such as toxicologists, neonatal specialists, OBs, high-risk OBs, you name it, people that were basically recognized across the country as the experts. And we thought that we would go through this process, develop some, products that we could use working with patients and with dentists. My group and my agency did a lot of the focus group testing that was involved. And still, we didn't really see the change that we were expecting. We didn't really see people embrace. And we know from translational research, medical research is done in these ivory tower, huge universities. And we know that it takes about 17 years for that to spread down to the actual practice of medicine. So I don't know why, in a way, we thought it would be faster with dentistry, but of course, we were hoping that it would be. That's why I've now come to grips with looking at my 20-year plan and not my 2-year plan. And in 2011, the National Maternal Child Health Center out of Georgetown did another consensus conference. And this was sort of to, basically try to reach the dentists and the OBs and the midwives and the caregivers, in the states other than New York and Texas, who maybe felt that they couldn't embrace those recommendations because it didn't come from their state. ACOG put together a great panel. I believe was thrilled to see that Monica put it on the table for those of you who like the researchy part. And this was another, stab at doing this, and it's a committee opinion, and I think it's a really well-written piece, and they pulled from a lot of the same research. So I'm trying to kind of summarize what I think the main pieces from that are. And realistically, we can look at all of these fancy diagrams, but the main issues that we have is that periodontal disease for pregnant women, it releases tumor necrosing factor. Does that sound like something that's good for a baby? Tumor necrosing factor? Probably not. Interleukins, which we know play a huge role in infection and infection, capacity and immune response. And that basically pulling all of those resources away from, nourishing and growing this fetus to helping the mother combat this infection in the long run is just not good for anyone involved. And we know that periodontal disease is really rampant. I mean, up to 40% of pregnant women have some form of periodontitis. We also know that in the United States, of people over the age of 35, 75% of us have some form of periodontal disease. I mean, huge numbers of people. More than likely, if you're seeing pregnant women, you could guess that 1 in every 2 of them, at the least, have some form of periodontal disease. We also know that cavities and caries are a major issue. And remember, that's the hard tissue disease. It's not the ugly brother or the pretty sister. It's a different process. And the thing that we're worried about with cavities in the mother is that they're going to transmit those terrible bacteria to their child and transmit them earlier and transmit them with a greater quantity of bacteria. Okay? So in California, Francisco Ramos Gomez, who I've done a lot of my research work with, in a group that he works with out of San Diego, almost 90% of the newly immigrated mothers that he works with in that site have some form of caries, most of it untreated. So in California in particular, since we have a lot of newly immigrated folks, the dental caries piece is really something that we all need to kind of be aware of and help people to combat that. So all these consensus conferences, all these committees' opinions, basically what it comes down to is that you're going to treat pregnant women the exact same way as you would any other healthy adult. Pregnancy is not a disease. It is not something that, for the most part, dramatically changes the way that people go about their life. There are a list of questions and some things that I do in longer trainings that kind of weed some of that out. And there are some cases where you do want to ask questions or you do want to consult with a physician. But that basically, I think this might be a good place to talk about the x-ray piece. So I get this question a lot. I also get, admissions from dentists who, come up to me after our trainings practically crying, saying that they've extracted teeth without x-rays because they were far more afraid of taking the x-ray than they were extracting the teeth. And that's just poor practice and, not what any clinician should do. But, I think if we take a step back and we put ourselves in the shoes of, say we're an emergency room physician. Would an emergency room physician order a chest x-ray on a pregnant woman if he saw clinical indications of pneumonia? Of course he would. Would he stop and worry about it? Would he call the OB? Would he, have to counsel the patient for 15 minutes? Maybe the patient would have some questions. But, chest x-rays, even the digital ones that they use in hospital now, are 800 times greater radiation than any whole series of dental x-rays. So we're talking about 22 dental x-rays. And dental x-rays are really, they're wonderful. The bones, your maxillary bone and your mandibular bone, where we take the dental x-rays, are some of the best bones in the body to take x-rays of. And if you took us all and cut one open, it would pretty much look like a piece of coral. There's very little soft tissue there. When they do bone marrow transplants, they usually take it out of, this part of the leg, because in those bones, if you cut them open, it would be a little bit of coral, but a lot of soft oozing stuff would come out of those bones, the bone marrow. And so it's the bone marrow that can really retain the radiation piece. The amount of radiation that you get when you're taking an x-ray, first of all, you have this beautiful lead apron collar that protects the thyroid. The drape is over the belly. The dental x-ray head is aimed right here at those two bones. With modern digital x-rays, the radiology experts tell us that there's less than 2 millimeters of radiation spread, which means at most you're going to go from here to here on radiation spread. And that's even using panos and some of the more complicated dental x-ray types of technologies that are out there. Women who get their a full mouth series get about 22 millirems of radiation exposure. And if you're putting food in the microwave and you're pregnant and you're standing next to it, you're getting about 200 millirems. And you don't even have a dental drape completely protecting you from it. Flight attendants who are pregnant are able to fly through their union and through their regulations until they're 4 to 5 months of pregnant, unless there are other complications. And with every flight, they get more radiation exposure, up to 80 millirems per flight than you do when you're getting an FMX. And they're not wearing a beautiful lead apron. So do they tell pregnant women not to fly? No. When you're a passenger on an airplane, you're getting radiation exposure because you're coming closer to the sun. Certain areas like Denver, just walking around in Denver, you're getting about 200 millirems per month walking around in Denver because you're a mile high, right? Mile High Stadium. And you're not wearing a dental apron. And it's not the best bones in the body to take the x-rays of. So I think if you can start to look at it, I have some more slides. I can maybe put it together in a smaller PowerPoint and get to Monica. And maybe that would help some of you sort of embrace that piece about the dental x-rays. We can't see all the cavities. We certainly cannot see abscesses that are way up here in the bone 90% of the time. There might be some clinical indication of it, but we can't definitively diagnose and treat as dentists without those x-rays. Okay, so let me get back to the rest of this. Was that good? Okay, thank you. So I think one of the other things that have come out of these consensus conferences, sort of getting back to that piece, was, really dentists, OBs, midwives, social workers, case managers still don't sort of embrace this idea that dentistry at any stage of pregnancy is safe. Any stage, not first trimester, second trimester, third trimester, what's optimal. Truly, all of the $7 million that have been spent amongst all of the agencies, Texas, South Carolina, and Oregon also did smaller consensus conferences. So in total, we have $7 million, over 85 experts who have testified in person, over 49 hours of expert testimony on this topic. And, we're pretty sure we can say this. This has now become the standard of care. When the National Maternal Child Health Center put out the consensus conference, this became the standard of care. There are very few other things in dentistry that we have this much written testimony and expert opinion on. And I think that at some point down the line, we may start to see some, patient-driven complaints or litigation sort of aimed at this. I hate to say that I've had 3 lawyers in the past year call me and ask me questions about perinatal oral health. And it made me sort of nervous to, be able to answer some of those questions. So what are some of the things that, as a very practiced perinatal oral health practitioner, do I have questions about? These are red flags. These aren't reasons not to treat, but these are things that I usually just ask additional questions about. If there are multiparous pregnancies, meaning that they're pregnant with twins or more, that just means that most of the time their uterus gets larger faster. So I make some adjustments to how I would physically seat them in the chair a little earlier than I would otherwise. I tend to ask because some, usually when you get into twins and triplets, there's a higher likelihood of some complications. So to be sure that the patient has had prenatal care and, is a good historian of their medical history and their treatment with their OB. If they're seeing a high-risk OB, I always ask a few more questions about that. But people see high-risk OBs for lots of reasons. I didn't have my first child until I was 37. So all 3 of my children, I've seen high-risk OBs throughout some of those pregnancies. If they were put on bed rest at any point or on pregnancy disability leave really early, these are all things that I would need more information about. If they have gestational diabetes, eclampsia, preeclampsia, if they've had, there are amazing surgical interventions that they can do during pregnancy now. They can go in and do fetal cardiac surgeries. So, these are all things that I would definitely need to have more information about and discuss with their caregivers. Or if they've not seen anyone for their pregnancy. If they haven't entered medical care yet, that's something I might wait a few weeks and help them get into care so that I was sure that they were screened appropriately for their problems. But again, these are not, necessarily reasons not to treat. And I think that when we look at this slide, it kind of hits 2 of the pieces that we were talking about. That the first piece under prime motivators is the transmissibility of the bacteria affecting the mother, her pregnancy. Remember, we've had all types of these oral bacteria that have crossed the maternal fetal placenta and her child. And there's that maternal burden of chronic inflammation and infection associated with periodontal disease. But what we really want out of this is better health outcomes, right? Better health outcomes. We know that with health outcomes, behavior is up to 40% of what drives health outcomes. McGinnis published this incredibly cited paper, and that health behavior piece, I think, is really what we're here to talk about. I think that's part of the advocacy, and that's part of the education that we're hoping to drive home. And I think that it's also a piece that kind of interconnects with utilization and access. And we really want to help the mother to reduce her oral bacteria quanta, or her load, the amount of bacteria in her mouth. Some of the work that I've done with Francisco Ramos Gomez is really looking at the mother and child as a dyad. The World Health Organization has an incredible program that they're developing. It's called the Continuum of Care, and it's really about the life course of the mother and the child. And they look at the mother and the child as one unit until the child is of age 2, one unit. And we know that when the mother has a high bacterial load, the child has the infant or toddler has a high bacterial load. Once they start to go off to school, some of that changes a little bit. But anything that we can do, and a lot of the reduction in oral bacteria really comes from better home habits, brushing and flossing, fluoride use, drinking fluoridated water, decreasing sugar intake, all of those kind of things. And delay of colonization, and that's sort of a fancy way of saying if, remember I told you that there were the bacteria that cause tooth decay can be found in babies' mouths as early as 3 months. I mean, there have been some studies that show it even earlier, but, women who have high amounts of dental decay causing bacteria can transmit it to their baby as early as 3 months. And really, this delay of colonization means if I don't actually transmit my bacteria to my baby until they're 3 or 4, they have a much higher likelihood, up to 20 times greater likelihood of never having any type of decay in their childhood. Once kids get to like 14 and they wear braces and they can make more of their own food choices, that sort of changes, but we're talking about that initial set of decay. And I think a lot of this really comes down to culture too. So we'll get back to that when we get to the education and the advocacy piece. I think the things that we look at in terms of changes to make in the office, if you're a clinician, your clinical office, if you're a program person, thinking of how you can take some of this back to your program, is really, reducing the mother's burden of dental disease, and also improving her unborn child's oral health, overall health, and oral health in the future. One of the pieces that I think is sort of important, as I said, we did some focus group testing for the California Dental Association after the Perinatal Oral Health Conference. And in these focus groups, we recruited 8 pods of people who all over the state, some urban, some rural. Average reading level amongst the groups was a 10th grade reading level. 10th grade education level, 5th grade reading level. So low income people, we had about 4 purely Spanish speaking focus groups, and the other 4 were English speaking. And the one thing that we found from all of them that was, the piece that California Dental Association Foundation called me into one of their meetings to really discuss with them further, was that pregnant women wanted this information not the day before they gave birth. They wanted it as early as possible. All throughout California, these women that participated in these focus groups, over 88 women, 86 of the 88 said they wanted it as early as possible, which was really interesting to me because at the time I sort of thought that I was an expert. And it's great when you find things that surprise you. And the other piece that they really wanted was that they didn't want to just hear it. They wanted to find a way that they could tell the rest of the village that's going to help them raise their child, be it their partner, their mother, their auntie, their husband, their sister, their child care worker, person who lived next door who was going to babysit their child a couple days a week. They wanted this information really early. So that's part of the reason the CDA, leaned towards making it a game in their perinatal brochure that they gave out, because they wanted to find a way to engage other people who were involved in raising the child, because it was very obvious that the women who were involved in these focus groups, it was mostly new information to them. The same numbers, 86 out of 88 of them did not know that they could pass their decay-causing bacteria onto their child. They didn't know it was transmissible. They didn't know it was preventable. They had no idea. But they couldn't fight the fight themselves, was sort of what they were saying. I can't be a salmon swimming upstream against everything. So really, we need to find ways to engage everyone involved in raising children and bringing children into the world. One of the things, we'll learn a lot from the third-party payers, the dental insurance companies. And one of the things that United Concordia did a few years ago was they looked at different types of disease models. And they looked at, was accessing, treatment for gum disease something that resulted in in medical savings for them. And they found with pregnant women, on average per year, if pregnant women received gum treatment, that they would save about $2,500 per patient. So, the insurance companies are looking at this in multiple ways. I've talked with 2 insurers who are looking at bringing this into their wellness programs. As people who are employed and you have access to commercial medical benefits, I'm sure you have, had some experience with wellness programs. Wellness coaches or nurse case managers who can help you, or even some of the commercial payers have, websites that you can go on and take PowerPoints that you can learn certain things, and they're starting to look at, oral health as one, and particularly for pregnant women. And we know that pregnant women don't usually go to the dentist. PRAMS, which was something that was done across the country, said at most 56% of women went to the dentist one time, and most likely it was for an emergency visit. So only 1 in 2 went during their pregnancy window nationally, and it was only for an emergency visit. And we know from some of the data put forth here, it was about 11%. So California is one of the few states that in their Medicaid program offers an expanded benefit package for pregnant women. And the fact that only 11%, and maybe that number, as it was, discussed, isn't as solid as we would like, but let's say 20%, only 20% of pregnant women, access their services. So there are a lot of things that we need to do to continue to help spread the message both to the provider community and to the patient community. We also know that younger women who are pregnant were least likely to go to the dentist while pregnant. And if you remember from one of those slides that, younger women are actually a big area of concern for OBs, because it's where some adverse, birth outcomes and troubled pregnancies, really show up. A lot of us know about older women having difficulty with pregnancies, but oftentimes it's very much the case for younger women, especially from, low socioeconomic backgrounds. We also know that, people delay their treatment while they're pregnant. They go, the JADA, the Journal of the American Dental Association piece that I put up there, women delayed dental treatment for their cavities until the first 60 to 90 days after they had their baby. So they suffered in pain instead of seeing the dentist, or the dentist told them to wait until after they were pregnant. So we have, multiple issues here. Lack of concordance amongst everyone involved with the maternal child world. We have, utilization issues. We know we have access and education of provider issues. So this isn't to tear us down, this is to start to kind of build us back up and feel empowered for the rest of the day. These are the questions as a dentist I always ask my patients, and that's the only thing that I sort of add on to their medical history about their pregnancy. And, realistically, the piece we would like to spend the rest of the time on is this counsel, educate, discuss, goal set, and really motivate your patients on oral health. There are all kinds of referral forms. I know that the LA County Basin uses their own set of referral forms for referring patients to dentists. So this is a little transition.
And oddly enough, knowing Frank was at the house made me feel better. Although I have no idea what he did there all day.
Do the baby fuck out, make the baby sleep. That's good, that's good. Little tin soldier, happy tin soldier, right? And now with an attitude. Hello? Who you? Get away. I don't like what you say. Now, legs up.
Okay, who doesn't love Martin Short? Father of the bride. Let's talk about behavior change, right? Behavior change is really hard. Those of us in this room probably spend a lot of our day wishing we could wave a wand and change that behavior. Remember, 40% of health outcomes are related to behavior, not to genetics, not to services. Only 10% of health outcomes are really related to the health services you receive. So, there's the theoretical part of behavior change, and then there's like the reality of when do people change? I know from working with a lot of nutritionists, adults really don't change their diet very often. If they do, it's usually a cataclysmic event. So you'll see some dietary changes across the board. You have a better compliance across the board after major heart attacks. And they've created these whole 10 to 12 week cardiac rehab programs that are really aimed at helping people change their behavior. And they do it right after the heart attack, as soon as they're stable enough. Not 6 months after the heart attack, not a year after the heart attack. They try to do it. They try to start folks who've had major MIs and have survived in 2 to 3 weeks after the heart attack. And they basically have them come into a hospital or a clinic setting. They work with cardiologists, nurse practitioners, OT, physical therapists, nutritionists. They take blood, they put them on treadmills, they hook them up to EKGs. They're asked to keep dietary logs, and they're coached, and they're, kind of involved in changing their life. And even those programs, after 5 years, still really only have about a 25% compliance rate. So it's a really daunting task. Any of us who've tried to go on a diet or give up smoking, we know how difficult some of these things can be. But the pregnancy window is sort of that magic wand. It is this beautiful time. It's a time when even a lot of the women that we treat who, have struggled their entire lives for just the basic things start to feel like there's hope for the next generation. My main job is working with a Native American community, and the Native Americans are very much motivated as people by either doing things for their elders or doing things for the next generation. They almost feel like it's shameful to do something for themselves. And I think that we have to really seize this opportunity in any way that we can. And I think that we see this with women. We see people who either completely stop or give up smoking, who've been smokers since they were 10 and 12 years old. We see people who actually change their diet somewhat during pregnancy. And we see people who have been chronic users of substances either completely give them up or really try to do so. So I think this is really the time. Remember back to the 86 out of 88 women who struggled their entire lives that we talked to with the focus groups. They want this oral health information as early as possible. They want hope and promise for their children. And when we talk about culture, I think in many cultures and in many parts of the US and the world, dental decay as kids is the norm. They've sort of never thought that they would have kids who couldn't have cavities. And when you really explain to people and work with them and discuss with them that, this is mostly preventable, you have a really good chance of your kids never having cavities. A lot of times they come around and they have that intention to change and the motivation that they don't have any other time in their life. And I think when we really look at this golden opportunity, if you're a provider, a dentist, it really, gives you the opportunity to bond with them for life, to, have generations of patients who are healthy and who look to you as their health expert. you have the opportunity to really provide that professional guidance. But I think that this thing about culture is a key factor. This is one of the things that the World Health Organization, it talks about in their continuum of care program that they're still enriching all over the world, and it's really one of the drivers. And we have, LA County is one of the hotbeds for promotoras and community health workers in the U.S. There are people learn from you in the LA County basin all over the country. And this, if you can change a few people, especially a few people who are good and trained in working with others, you have the opportunity to really get the snowball rolling. And one of the things that I've been doing a lot of work with recently is motivational interviewing. And if you're on the provider side or the direct patient interaction side, it's a really incredible tool. It challenges you to think differently. Instead of, as a dentist, you should have flossed, it becomes oh, hi, Mr. Eisman, when you were here last month, we were talking, you were saying that you were really thinking about flossing more often. How's that going? Have you been able to make those changes? And, really talking with the patient and asking permission, Mr. Eisman, is it okay if I offer you some suggestions? Instead of me saying, Mr. Eisman, I can't believe you haven't flossed. Let's go over this again. And so it really changes the, entire process of interacting with patients from a you and me to a we. And we know that we're not going to get people to motivate and to change unless we come at it from a we approach. Health coaching is another area that, hospitals and Kaiser and some other, larger practice groups are starting to really embrace. And part of that is because we know that the health coaching piece really works. We've seen changes in health behavior that we've never seen with any other type of process, with things like heart disease and diabetes. So, I think we can start to take some of those things, and that's, really what I'm hoping my next 10 years of work is going to focus on, is the motivational interviewing, the health coaching piece, the wellness program, because I think that, sometimes you really just need to work with the patients and go at their pace, and their goals may not be what your goals are today, but it's really, giving them the information, letting them come to it. So, one of the things that I would love to see is, when will we get to this magical carie-free zone? When will we start to have 5- and 7-year-olds in this country who don't have any dental decay? Right now, kindergartners in this country, more than 60% of them, 50 to 60%, depending on the studies, have already had caries experience. And in some communities, so in San Francisco, where I work, we have 2 pockets of newly immigrated folks where we have lots of people who've come from other countries, and they have up to 78% of dental decay by kindergarten, 78%. And this is, again, transmissible and preventable. So we're not doing what we need to be doing to help people to change, their behavior. Some of the things about oral health promotion and disease prevention is that starting early. Remember, 80 out of 88 women in this state, that was a very representative group of low-income folks, said they wanted this information as early as possible. In the San Francisco area, neither Kaiser nor Sutter Health, which are the 2 main players in babies, have anything in any of their books or information that they give to pregnant women about oral health, about seeking oral health, about preventing decay, about risks associated with periodontal disease, about going to the dentist. I know that OBs have a lot on their plate. I would love when they, ask their patients, do you have your pediatrician lined up yet? Who will it be? That they also have a second question, who will your pediatric dentist be? Have you talked to your dentist? Will they see your baby before the age of 1? And I think that there are all kinds of people that we could really reach in that interprofessional piece. Maybe it's folks we haven't thought of before. Maybe it's the ultrasound tech as they're, setting up the ultrasound machine. Maybe it's, a video that we show while they're, waiting for their next OB visit. Maybe it's the medical assistant. Maybe it's the front desk person. Maybe it's you. Maybe it's your role. So I think that, it's that all caregiver piece. And when we look at community outreach, there are lots, it's very multifaceted, as we know. But I think that, the things that tend to get people, when I see the light bulbs go off, I saw some of these light bulbs in this room, transmissible and preventable. I saw it from people in this room. So, what works in your community? Start to think about it as you're giving health, any type of health behavior message or discussion or health coaching or motivational interviewing. When do you see that light bulb go off for someone? And change what you're saying, not just a script, change what you're saying to try and really capture that moment. And I think that we could all use more time and more practice in doing those kinds of things and having not just role playing, but real playing, where we have, in really big hospital groups, they have paid actors that they have come in and do, pieces that they call real playing. And, that's some of the things that we know really work. But there are lots of other kinds of, trainings that you can either seek or take or ask for that are really around that piece. OHI is oral health instructions. And, at my clinic, we're changing that. And we're trying to come up with something that has a little ring. So we're sort of, toying with, patient oral health care discussions. So POCT, we don't know what we're going to call it, but we're going to now take it off of the list and change it to something else that it represents more of dialogue between the patient and the provider, not instructions. And again, that culture piece. So we know that lots of people in San Francisco and in LA and throughout California come from countries where they cannot drink their water, where they are really fearful of drinking water. And we have all kinds of studies. I do some work with the Can Do Center at UCSF and in Central California. People go to water stations and get their water filled because they're so fearful of the free water that we have, the free, wonderful water that's maybe dwindling in the state, but that we have. And that exposure to fluoride, the optimal fluoride level, is really important as a first round defense in especially early childhood caries. So you kind of have to know your culture. You have to make sure that when you're putting out information in written form or speaking with patients that you're doing it mindful of what their reading levels are or what their English proficiency is or what their dialect might be if they speak Spanish, so that you're really doing the best job that you can to really engage and work with people. In this situation, we have a dental assistant who's using the CDA brochure to work with the dad. And you can see the little stuffed animal going over with the dad how to wipe off the teeth or how to wipe off the gums once the baby's done with feeding. So again, real playing and role playing with your families if you have someone in your group who can do that. One of the things that we do really successfully at my agency and has been a complete godsend to us is that we work with AmeriCorps volunteers. I think you have AmeriCorps in LA through CCLEC. So, the AmeriCorps program, this health education piece is part of what they're meant to do. These are young folks who are really motivated to go to medical school or dental school or to get an MPH. So, if you have an AmeriCorps person, think about adding a second one for your dental program. If you don't have an AmeriCorps person, think about fighting for one. JVC nurses are another great way, or even building volunteer programs through your community, especially if you're, associated with one of the dental schools, and, asking dental volunteers, people who are interested in going to dental school, to give you X number of volunteer hours. And in return, you're going to write them a wonderful letter. You're going to campaign for them. You're going to practice. I coach our volunteers who are going for dental interviews, so that, you end up not always having to have paid professionals being the one to spread this message. We talked a little bit about promotoras and social workers and community health workers. So again, it's all caregivers, and if you don't have the type of caregiver that you need, think of ways to recruit them or build them. Looking at how do you reach people? We know that there are lots of different ways. There are mailings, there are face-to-face approaches, there's a community-wide approach, there's provider network and education capacity building, There are wellness programs and other types of educational things you can put for patients to find. I think the first 5 of LA is, working with more than several dental community clinics in the area to really try and change some of this, both in terms of provider education and in terms of access and working interprofessionally between medical and dental programs. So I work with that project a little bit. I'm the expert advisor to one of the community clinics, and one of the best things about working with that community clinic is that I've had the opportunity to talk to the CEO, the CMO, the COO, the CFO, and getting those folks involved and those folks on board, and I've seen their light bulbs go off. And I changed that discussion a little bit. I mean, part of that discussion is how they can increase, revenue, and how it's, a type of visit that doesn't require a lot of provider time. And, they look at things a little bit differently, but they're obviously there for the same reasons we are. They just have a different eye. One of the things that I think was a really great program was in 2009, there was a young man named Diamante Driver who died in Maryland due to a dental infection, and it was big news. Almost every dentist could tell you about it. And he died because he couldn't access Medicaid services. He had Medicaid coverage for his dental care, but there was no provider in his area. And if you talk to folks who are in the dental benefits industry, they'll tell you their asset is really their network. So part of the work that needs to be done is really in that network building and that network education piece. And it's hard to reach providers, especially dentists. It's hard to get through to them because they're in their private practice. They're in their little world, and they're trying to run a business. And in the community health center world, a lot of times we have to go through the CMO and the CFO and the COO. So I think that there are lots of things that we're going to learn from this First 5 LA project that will hopefully we can start to crack that nut. And I hope we can do some more work with the C-suite, that executive suite that runs some of the community health centers that provide so many services in California. And in 2011, DentaQuest targeted Maryland and Virginia to try and really increase their utilization. So they did some work, obviously, and the state really did a lot of the work for them because they went in the state of Maryland from having 30 cents on the dollar payment for Medicaid to having, I think it's 92 cents on the dollar. So now dentists became very motivated to participate in the Medicaid program. So that was the first thing. But even after they did that, they really found that young children, if you remember from the data that Monica showed, very poor utilization data from children 0 to 3. Dental decay, when it's going to start in little kids, it starts by 3 months, 6 months. It's already waiting for that first tooth before the tooth even comes into the mouth. So by just the first mailing to families that they knew were eligible, they had a 40%, I think it was 38.7% increase in getting kids under the age of 1 to the dentist, just by one mailing. So I think sometimes we, need to turn over every rock that we could. They did some more work on this and even had some better numbers by looking at face-to-face approaches. They had case managers who called families in areas to try and reach more people. I mean, they really kind of pulled out all the guns to try and really change those numbers. And, I think that we sometimes have to look at it a little bit differently. Getting back to the counseling for pregnant women, I put some abbreviations up here, but AG is the anticipatory guidance. And, that's really looking at when do you give up the bottle? When do you give up the pacifier? When do you, what are sort of like the nursing priorities, and how do you stage that with the child's age and the child's development? OHI is the oral hygiene instructions, which I said we're changing. The next time I speak, I'm going to have a fancy, cute term that you all can put your arms around on. And, also that nutritional counseling piece. I mean, realistically, little kids should have, at most 30 to 40 grams of sugar per day. That's kind of the guideline. You know how difficult that is? I mean, I'm a mom who really puts a lot of time and energy into that. And a few weeks ago, I went and bought Scooby snacks, which I thought would probably be a healthy thing to put into my kids' lunch. And it's, it looks like graham crackers, but I guess it has a little tiny bit of a sugar coating. I looked at the package. It was one of those pre-formed little things you can throw into the lunchbox. I looked at the package, and daggone if it didn't have 23 grams of sugar. So, yogurts are wonderful. I'm starting to dilute my children's yogurt. I give them Greek yogurt every morning because of the high protein content, and, but 23 grams of sugar. So now they don't like the non-fat plain kind, so now I'm diluting it the same way that I, advocate with our parents to dilute the juices in the bottle or the juices in the sippy cup. So it's painful. I'm in the process of changing what I'm trying to give to my children, and it's painful, and I have to tell everybody, my husband, my in-laws who are visiting, my babysitter. I have to coach everybody and pre-mix stuff, and it is really tough to get everybody on board. So I understand those women now, thinking back to it, those 86 out of 88 women that we talked to who didn't want to be the salmon swimming by themselves upstream. And, some of the things that we look at is discussing Carrie's risk factors with parents, choosing one or two of them to really discuss with them. And, I think some of the important pieces are, have they had cavities and caries within their family and within the mother in particular or siblings? And what kind of fluoride exposure? Are they drinking tap water? One of the simplest changes, and it will save them money. And, getting people really to embrace that is tough because it's in their culture. For generations, they've been scared of their drinking water. And if you've tried to, really work with people to change that, you'll realize how tough that can be. So this is a list of some of the known risk factors for toddlers and babies in terms of caries. The mother with untreated decay is probably one of the number one known caries risk factors. Also, visible plaque on the teeth, which is in the second column, or two, and existing gingivitis. We don't usually see gingivitis until, maybe the teen years. So when we see little babies with gingivitis or 2 or 3-year-olds with gingivitis, we know that they're really not toothbrushing, and they're not toothbrushing with the parent. As a parent, you should help your child toothbrush until they're 8 years old or till they're able to write their first and last name in cursive because they don't have the dexterity and the hand skills to be able to do it. So, sometimes I brush my children's teeth first and they brush it afterwards. Other times I let them start, but they know that whenever the toothbrushing time is over, at some point I'm driving. And, sometimes that's a more difficult battle than others. Mother with recent decay within the past 2 years, having fillings in the past 2 years, makes them at much higher risk for cavities, high sugar diets. So, if you work in a community or live in a community where there are really just convenience stores and not a lot of fresh fruits and vegetables, that, you're probably, most of our patients and their families live on high sugar diets on convenience foods. Poor oral hygiene practices. We have some families that come in and, they're so excited to get a toothbrush because they have one toothbrush that they share within the whole family. Low socioeconomic status and ethnicity, unfortunately, are some of the really prevalent factors for oral health disparities for cavities. Newly immigrated, we see huge percentages of newly immigrated folks. I had a patient 2 weeks ago who came in, a young woman who was pregnant, and she was so excited to meet a dentist. She had never met a dentist in her life. She had had teeth extracted, so we asked her where she had had this done then, and she went to the barber the next town over, and that's who extracted teeth in her town in Guatemala. So, I think that even though many other countries have wonderful public health systems that include access to hygienists and dentists, I think there are still very rural areas in those countries. And in the U.S., look at all the Moms and Rams programs that, have people lining up. But, newly immigrated folks we know have a much, much higher risk. Poor maternal nutrition is also a problem because, again, it's that dyad, right? The World Health Organization sees the mother and child as one unit up until the age of 2. So if the mother's not eating well, the baby's not eating well. Other chronic diseases, caries is the number one childhood disease. 7 times more common than allergies and 5 times more common than asthma. huge separation in the incidence and prevalence between caries and any other childhood disease. But when kids are on asthma, when kids have asthma, they're taking nebulizers, they're taking inhalers, they're taking other medication that causes their natural saliva to go down, and the saliva is a really protective factor. So in some cases, there are salivary characteristics that we're really just in the process of starting to understand, where some people's saliva quality is not as good as others. And this extends to children. We're looking at some salivary markers. It's not really anything that the two universities who do most of this work in are ready to, completely stand behind. But some of the initial studies, we know that there are some families that have, the genetics is 10% of it. There are some families whose saliva just isn't as good as other families or other individuals. So there are lots of other reasons, but poor access to care is certainly one of them. And utilization, if the child isn't seeing the dentist until they're in kindergarten, we've got big trouble. Okay. So I'm going to get to some questions. I did just want to show you Cavity Keep Away. This is the brochure that we helped develop from the California Dental Association, and there are lots of different messages, but one of the ones that we tried to hone in on here was using fluoridated toothpaste and using it as soon as the teeth come in. Not 3 years later, not 5 years later. The American Academy of Pediatrics and the American Academy of Pediatric Dentistry and the American Dental Association now all say, after spending all kinds of time and money in researching, use fluoridated toothpaste as soon as the first tooth erupts into the mouth. So that was one of the messages we wanted to get across. The other was really talking about saliva sharing practices. If you are testing your baby's food to see if it's hot with a spoon, use a different spoon, one you test with and one you feed the baby with. If the pacifier falls on the floor, you don't pick it up and wipe it off with your mouth. You don't share soda bottles or water drinking bottles with your child or between siblings. One of the more controversial things was, do you kiss your baby on the lips? That's a saliva sharing, process. So we didn't really talk about that because we just knew it was a little too controversial, but it is one of the ways that you exchange saliva and can transmit those bacteria. So let's do this. What is the number one childhood disease? Ooh, okay. And let's see. I have another sentence, and there's going to be 2 blanks. Caries is blank, and caries is blank in children. All right, you guys all pass. So before I get to the questions, I think I have about 10 minutes, 5 minutes? Okay. So, creating oral health programs. Well, not all of you are dentists and looking at creating those types of programs, but I think part of it is, how can you build a team? How can you start to talk about this in your projects and your programs and in what you do in your professional life? And these are questions that, really only you can answer. I think if you are involved in quality improvement programs, that's a really great place to start to test this out. And if not, I'll just talk, briefly about that. You want to look at small tests of change. Ask, your medical assistant or your dental assistant, go through some of the trainings that are available on oral health, and just ask them to ask one question to a pregnant woman as they're seating them. And, say that day she needs to ask 3 pregnant women that she's seating into the medical exam room before they see the OB about their teeth. Or have you seen a dentist while you've been pregnant? And then just have them report back to you. And then start to grow it. You need to find champions within your programs. And you need to find people who you've seen the light bulb go off and that you can work with to try and engage others in this conversation. And there are lots of ways, in terms of expanding this and really creating access points. But I think I'll stop there and go back to this part, the questions. And I'm happy to answer clinical questions as well, since that's usually, a 2 to 4 hour lecture that I do.
Hi, my name is Katie Balderas. I'm with LA County Comprehensive Perinatal Services Program with the Department of Public Health. And I'm wondering if there's kind of a packaged health education curriculum that's already developed for pregnant women to educate them on all of the things you just talked about.
There is not. I mean, there are lots of maternal child access has some, written materials. California Dental Association has some written materials. Maternal Child Health out of Georgetown, they have some written materials. So are there program materials? Yes. Is there sort of what I would love to see if there are any funders in the room? Let's develop a, self-learning module that would really be out there for, either pregnant women or for providers or program people to really start to look at, that say 20 minutes in length that can sort of hit on some of this. Do you know of anything else, Lynn? Yeah. Yes, Bob, do you know?
Yeah, California Perinatal Services Program at one time had a hygienist who worked for the MCH program that developed some materials for that program. I don't know if they're still out there. It's not exactly a curriculum. Yeah.
Yes.
Like more of a guide to teach a class, because a lot of our
Yes.
providers do group classes, and it's really nice to have this is your introductory question, this is the discussion that you facilitate, and these are your talking points. And here's a handout that goes along with it. And that handout could come from CDA, CPSP, there's a ton of written materials, but there's not like a
Right.
guide. And especially going back to what you were talking about with motivational interviewing, I think it requires a lot of practice, and I think having a guideline such as a curriculum is really a helpful tool in practicing and really perfecting that motivational interviewing around oral health.
Yeah, and I think that would be great. I mean, I've done similar things with the University of the Pacific around just public health in general, but some of the things that we include are, modules that teachers could use during, teaching time. That includes, getting students to go and look for other materials, and I think that, it would be wonderful. I know that First Five of California, several mid-2000s, had some learning modules on early childhood caries that had one or two slides on perinatal, but I don't think that is accessible anymore. But that was a good place to start. That's like the what I know of most.
The stuff that Lisa Chung has done with this, is it centering pregnancy? Or?
Yeah. So Lisa Chung is a researcher from UCSF who has done a lot of work with Sally Adams through the Can Do Center, and it's looking at centering pregnancy and embedding these perinatal oral health messages into the entire prenatal program. And, it's an NIH-funded project, so the stage that they're in right now is still very researchy oriented, but the lessons learned that are coming out of her findings from the first pilot project, her second project, which is a much bigger project, has now been funded. So I think she is looking to publish that in the next couple of months. So there are some lessons learned. Yes. Hold on 1 second, if you could wait for the mic, please.
My name is Mina Habibi, and I'm from USC. Regarding the curriculum, we are actually developing a curriculum for the health professional and oral health professional, and then once it's ready, we will be more than happy to share it with the.
Wonderful. And is that specifically on perinatal oral health or early childhood oral health, or kind of all?
We're working on a project funded by LA 5. It's for children 0 to 5. And part of the program is prenatal care. And my role is professional education with regard to prenatal and postnatal, both medical and dental provider. And I actually noticed myself that we don't have the curriculum, and I'm in the process with the help of the other team member in the process of developing a curriculum for prenatal care.
Fantastic. And what do you think the timeline for that, for completion?
We're hopefully by the beginning of September,
Oh, of this year. Well, that's pretty quick.
Yes.
Okay. So, I mean, that's sort of the answer. The Healthy Smiles is something that's available online that a lot of people use just in terms of training people and looking at things and how to look in the mouth and what to see in the mouth, or when to kind of triage or screen or have a dental professional look. So, that is not a full-blown curriculum, but it's a very often used resource by other professionals outside of dentists and hygienists across the country. So that would be another place to look. We have a question back there in the yellow vest.
Good morning, everybody. Lilia Fuentes. I'm a dentist working with Altamed. We are a federal qualified center, medical center. One of my concerns is regarding the medical consent.
Yes.
I have read a lot. We know that pregnant is a healthy women, but still we have a lot of hesitation to work on them if we don't have that medical release. So what is your advice?
Yes. So again, this is one of the most other often questions that I get aside from the x-rays and sort of the trainings to dentists. And I think that this really comes down to understanding our licensure. You know, as dentists, we don't work under physicians. We're not a nurse practitioner or a physician's assistant. We have our own medical license to practice in the state of California. And we need to understand and be comfortable in what that means. There is no such thing as obtaining medical authorization from the physician. It doesn't stand up in court. Basically, the physician can give you information, but there is no such thing as medical consent. They can offer an opinion, but realistically, it comes down to what you see and what you think outweighs. If it's a patient that, you know, has a life-threatening dental abscess, and, you know, the physician thinks that the tooth shouldn't be extracted, you know, ultimately it's your decision. And there is no court of law that would hold up, where you would go in and say, well, I didn't extract the tooth because the doctor told me not to. You have your own professional license, your own malpractice. And, you know, I think that there is often that when things get sticky, dentists like to defer to the physician so that they don't have to make those decisions. And I think it really comes down to the professional education piece. And I think that that's one of the things, you know, in speaking to a couple of CMOs, that once they think about it, they're like, well, you're absolutely right. You know, they are independently licensed professionals. So, you know, sometimes I think it's the individual provider, the dentist. Sometimes it's the organizations within where they work that have sort of those control issues. But ultimately, you know, you need to educate yourself more on kind of the perinatal process and be comfortable in making those decisions, because medical consent does not exist. It is not a thing. I do some medical claims review for the Indian Health Service, and there's no such thing as medical consent or, you know, pre-authorization from the physician. They can offer advice, they can give information, you can work with them to adjust treatment plans or to hospitalize patients, but a physician writing you a letter is not clearing you of your professional duty.
Also, we had one member from the California Dental Board coming to our place and talk to all of our dentists. And at the end, I have the questions for him, because we were about to create, we had the policy to don't ask anymore for consent forms for any of our medical doctors. And I asked him what was his opinion on that regard, and he said that having one medical consent won't harm us. So I was like, so then what? Do we or not? But it's just because when we go, I haven't been in any of those law issues.
Right.
But I don't know at that level if that consent will be useful, or as you mentioned, it's just we are all up to our license.
Yes. Well, and I think it really comes down to document. You know, in other trainings I go into, if you don't treat or you choose to delay treatment on a pregnant woman because of one of the issues that we had briefly went over, or the patient was a poor historian, the main thing to do really in terms of covering yourself for risk management reasons is document. You know, put into your note that you reviewed the medical, you know, information that you received from the physician. You took that into consideration along with the clinical presentations, and you chose to alter treatment for this reason. But alone, a doctor telling you to do or not to do something will not absolve you from your professional sort of duties and from, deviating from the standard of care. You have to document other reasons.
Great. My question is an elaboration of hers. Actually, pretty much I work with a lot of OBGs. All you're going to get from them is you use a ledaprine, use lidocaine without epinephrine. That's pretty much it. So they're not going to get into your mode of treatment. The question that I actually had from you, I see a large number of minors in the practice, anywhere from 14 to 17. And my question and hesitation has always been, can they sign the informed consent? I've spoken to the board about it. They didn't have an answer. I've spoken to malpractice carriers. They don't have an answer of whether once a woman becomes pregnant, do they have the consent, although they're under the age of 18?
Right, and is this on the dental consent or the medical consent?
Dental consent.
Yeah, they do. Once they are pregnant, they basically become a liberated adult in terms of medical consent.
Okay, perfect, thank you.
And if you, TDIC, which is the California Dental Association's, liability company, has some information on that. So if you call their 800 number or call that CDA professional helpline, I forget what they call it, they can get you the documentation that you might need to put into policy at your site.
Perfect, thank you.
My name is Rachel Goldberg from Valley Community Clinic, and I was wondering, when is the best time to provide dental treatment for the pregnant patients? Because when I went to school, they always said the mid-trimester.
Mm-hmm. Thank you. And basically the consensus conferences, the overwhelming, one of the overwhelming statements is that it's safe to treat women at any stage of pregnancy. Now, once they get into the later stages, if they're just having one baby, 7 months or older, the 7 months along or greater, or if they're having twins, it might be a little earlier. You want to put a small pillow under the hip of the patient because the uterus is really large, and laying back in the dental chair, the uterus can actually impinge on the inferior vena cava and cause the patient to faint. So you make a small adjustment there. But realistically, we know from all of the studies, and I'm surprised I haven't gotten any questions about the studies. There have been a lot of studies that have been done in the past 10 to 12 years that have been funded looking at, does getting dental treatment for, gum treatment during pregnancy change birth outcomes? And we've had all kinds of different modes of study. And, the one area where we think that there is probably an association is a decrease in preterm births. Marjorie Jeffcoat, did a really one of the most structured studies, and that was her outcome, decreased preterm births by up to 84%. But we haven't really cracked the nut. Now, with cardiovascular disease, we have, over 50 years of research across the world. And even though we know what some of the strong indicators and risk factors are, like high cholesterol diets, those kind of things, still 1 out of every 2 heart attack, we don't necessarily know why it happened. So I'm not giving up on, the research. There have been, I think it's something like $1.4 trillion that they know of that's been spent on cardiovascular risk factors and heart attack association. And comparably, in this country, we've spent $41 million on the perinatal-periodontal relationship. So we haven't put enough money into it. We don't have enough time into it. But I know your question was when to treat. And some people in dental school were told never to treat, only treat if you absolutely have to. Hope that they go away. Tell them you can't see them. Really, this is what I was taught at University of Maryland. I was told, don't see them if you have to. I remember it was in the emergency clinic, and I had a pregnant patient who came in and wanted a tooth distracted. And the world was a flutter for about 3 hours until we decided we would do it, but only in the hospital. So, this is not news, and different faculty, different schools. I believe the universities, while I work with them and I love them, I think that they have been very slow to sort of change their policies in the way that they teach this, if they teach it at all in their predoctoral programs. I think sometimes they Some of the schools have done a better job than others in actually incorporating it into the curriculum. I've written a couple of questions into the national board exam, and the first two on perinatal oral health were just accepted. So, they teach to the exam. So I'm hoping that that might change some of it. And, but even when they get into the clinic, they're often supervised by, faculty who are just there one afternoon a week. They're in private practice the rest of the week. And there's really no calibration of what those faculty say to the dental student. And oftentimes, they have more impact on the way that, a young clinician is going to practice than, the faculty they've been listening to for the past 4 years. So I think there's a lot of work that still needs to be done on that university piece. I'm glad to hear that USC is involved in doing something about it. I'd really love to hear that it's, going to be incorporated into years 1 through 4 and part of your problem-based learning. And I know that UCLA is doing some work around this. I don't know that it's gotten to the point where it's really involved in their curriculum, but again, it's not on the test, so they don't spend much time on it, and oftentimes it's that one faculty who covers you for, restorative on Tuesday afternoons in the clinic who tells you, no, you're not going to do this while I'm covering you, and that's all it takes. I think one of the other things that, is oftentimes an issue is maybe the dentist drinks the Kool-Aid and is on board with perinatal oral health treatment, but their front desk person might not. So the patient calls, and the front desk person tells them, oh, we don't see pregnant people. Call us back in 6 months after you've had the baby. So I think that, we have to look at the entire team. One of the things that I'm hoping that comes out of the first 5 UCLA projects is that we really learn a lot about that piece. And, the interprofessional roles, I think, we know that health behavior change comes when you embed messages. We know that a patient is much more likely to change a health behavior when they've heard it between 6 and 10 times in a 6-month period. And that's sometimes reading it, sometimes hearing about it, sometimes something else. So embedding those messages and making sure everyone's at the same comfort level is really important. So I'm available the rest of the day, and feel free to, contact me personally with any questions. And I hope that you all enjoy the day and do some good work from this.